Hello everyone, my name is Jacqueline Chu and I'm an internal medicine resident at Massachusetts General Hospital. I will be discussing our paper, Surgical versus Endoscopic Management of T1 Esophageal Adenocarcinoma, a modeling decision analysis. The purpose of our paper was to explore the optimal management of early stage esophageal adenocarcinoma, specifically stages T1A, which is confined to the mucosa, and T1B, which invades into the submucosa. Traditionally, early stage esophageal adenocarcinomas are removed by esophagectomy. But recently, treatment is moving more toward an endoscopic approach because of advances in endoscopy and the high morbidity associated with esophagectomy. In fact, national guidelines now recommend either esophagectomy or endoscopic therapy for T1A esophageal adenocarcinoma, but prefer endoscopic therapy because of the similar outcomes with reduced morbidity. In contrast, the recommendation for T1B tumors is still esophagectomy, given the higher risk of lymph node invasion with these T1B cancers. Despite this, rates of endoscopic therapy for T1B cancers are also increasing in the United States, particularly for patients aged 75 and older. This may be because these patients were poor surgical candidates or had significant competing comorbidities. For patients with already reduced life expectancy from their comorbidities, it's unclear whether the relative gain in cancer-related survival is worth the cost and quality of life with esophagectomy. We want to explore what patient factors, particularly age and comorbidities, might change the optimal therapy of early-stage esophageal cancer from esophagectomy to endoscopic therapy. To do this, we developed a decision analytic model to look at the effectiveness of esophagectomy versus endoscopic therapy for T1A and T1B esophageal adenocarcinoma. We looked at this in terms of overall survival and quality-adjusted life years, which takes into account quality of life, and at the cost-effectiveness of esophagectomy versus endoscopic therapy. We created simulation models of a randomized clinical trial where patients would be treated with either esophagectomy or endoscopic therapy. In this simulation, we follow a hypothetical cohort of patients in each treatment arm until death. Over time, they can die from complications of treatment, die from cancer, or die from age, sex, and comorbidity-related mortality. For T1A adenocarcinoma, our modeling analysis found that for our average patient, who is 75 years old with no comorbidities, esophagectomy still provides slightly better overall survival compared to endoscopic therapy. But because of the morbidity of esophagectomy, endoscopic therapy was preferred in terms of quality-adjusted life years, and this is true regardless of age between 60 and 85, comorbidity index, or combinations of age and comorbidity index. The only factor that changed the preferred treatment for T1A was the patient perception of quality of life after treatment, also called the utility. In this chart, the x-axis is utility or perceived quality of life after endoscopic therapy, and on the y-axis is utility after esophagectomy. The optimal therapy would change from endoscopic therapy in blue to esophagectomy in red if the patient's perceived quality of life with esophagectomy was at least 97% as good as it would be with endoscopic therapy. For T1B cancers, for our average 75-year-old patient with no comorbidities, the optimal strategy for both overall survival and quality-adjusted life years was esophagectomy, which would be expected due to the higher risk nature of T1B cancers compared to T1A. The optimal strategy did change, however, from esophagectomy to endoscopic therapy based on the patient's combination of age and comorbidities. Age by itself did not change the preferred therapy from esophagectomy to endoscopic therapy. But for patients who were both older and had comorbidities, the strategy tended to move toward favoring endoscopic therapy. Here are the results of preferred therapy based on the combination of comorbidity index on the x-axis and age at diagnosis on the y-axis. As the combination of age and comorbidity index increases, the preferred strategy moves from esophagectomy in red to endoscopic therapy in blue. Similar to the T1A results, the patient's perceived quality of life after esophagectomy or endoscopic therapy was also an important factor that could change the optimal strategy. Esophagectomy for the T1B cohort was only cost-effective for age 60 to 70 with comorbidity index of 0 to 1. So to summarize, for patients with T1A esophageal adenocarcinoma, endoscopic therapy is the preferred treatment strategy across a wide range of ages and comorbidity indices. In contrast, for T1B esophageal adenocarcinoma, the decision to treat with esophagectomy versus endoscopic therapy should be an individualized decision, factoring in the patient's age, comorbidities, and quality of life preferences.